Right, so we want to talk about the lungs and the pleura around them. Right. So remember, for the last time we were talking about the thoracic wall, and we say that from the outside it's skin, superficial fascia, deep fascia. You meet the pectoral muscles. Then after pectoral muscles, there is external intercostal, there is internal intercostal, then there is innermost intercostal. And then after innermost intercostal, there was endothoracic fascia. After endothoracic fascia, we get to this layer here, which is parietal pleura. Then after parietal pleura, we get to visceral pleura. Visceral pleura is the one that closely invests the lung, which is firmly adherent to the lung. Right? And the space that is between the parietal and the visceral layer, this cavity, is what we call the pleural cavity. So the lung is not inside the pleural cavity. Pleural cavity is a space between parietal pleura and visceral pleura. And these pleura are simply serous membranes that surround the lung and they support it. And I also remember telling you that parietal membranes are sensitive to PTTP, pain, touch, temperature, pressure. Visceral membranes, on the other hand, they are sensitive to stretch and tear. Right? Meaning to say that visceral membranes, they get their innervation from the autonomic nervous system, whereas parietal membranes are innervated by somatic nerves, the same nerves that innervate the body wall, which is sensitive to all those sensory modalities. Right. So within that pleural cavity, the space between parietal and visceral, there is usually a thin film of pleural fluid, usually about 5 to 15 mils of pleural fluid, which helps reduce friction due to lung movements, right? So that pleural fluid can become elevated in cases of pleural effusion. So think about someone with TB, for example. They get a buildup of fluid in that region, which will need to be drained by a chest drain. So you need to be able to know the layers that you pass through when you are passing a chest drain to drain excess pleural fluid. So you're starting from skin, superficial fascia, deep fascia, pectoral muscles. Then you go external intercostal, internal, innermost, you go endothoracic, you go parietal pleura. Then you are now in the pleural cavity. You don't pierce the visceral pleura, because the moment you're now piercing the visceral pleura, it means that you are now piercing the lung, right? Okay. So maybe not this picture. No, let's see if I can get the picture. Okay. So parietal pleura. So all this is in blue here is parietal pleura. So we divide parietal pleura into four. There is a part of parietal pleura that covers the lung in the neck. So when we talk about the lung, you realize that the apex of the lung is actually in the neck. The pleura that covers the apex of the lung in the neck is called cervical pleura. Then the pleura that covers the part of the lung which faces the ribs is called costal pleura. Then the pleura which covers the part of the lung that faces the diaphragm is called diaphragmatic pleura. Then more on the inside there, we have something that we call mediastinal pleura. Why am I calling it mediastinal pleura? It is because that thoracic cage, when you place the two lungs on the sides, the rest of the space that remains behind is what we call the mediastinum. And we'll talk about the mediastinum in a separate talk. Right. So the surface of the lung that faces medial, where the remaining space is that I'm calling the mediastinum, is what we'll call the mediastinal pleura. Right. Then, in as much as parietal and visceral are different, the two layers of pleura, which is your parietal and your visceral, they become continuous with each other at what we'll call the hilum of the lung. So I'll show you what the hilum of the lung is and what you find there. But it is at that point where the parietal, specifically the mediastinal part of the parietal pleura, becomes continuous with the visceral pleura. Visceral pleura for the lung has no parts like the parietal where you divide into 4 parts. Right. Then we have what we call recesses. Recesses are just pockets of spaces between your pleural reflections. For example, there's a space between the costal and the diaphragmatic, which we call costal diaphragmatic recess. There is a space between the costal and the mediastinal, which we call costal mediastinal recess. Right. So recesses are just pockets of spaces within your pleura. And these spaces allow for the lung to expand into them during inspiration. But even if you fully inspire to whatever extent, you will never completely feel the recess. Right. Then remember I said in terms of innervation, visceral is innervated by autonomic nerve fibers. So autonomic nerve fibers for the thorax, all parasympathetic innervation for thoracic organs is derived from the vagus nerve. Then sympathetic, we just say T1 to T4. Right. And these are surface projections. I'll teach you surface anatomy of pleura together with surface anatomy of the lungs. It would be useless to talk about one and not talk about the other. Right. Then, which lung is larger than the other, guys?
Right lung.
Right lung. Which one's heavier than the other? You just said the right is the larger. So which one's going to be heavier?
The right.
The right one is going to
Right.
be heavier. So the right lung is about 700 grams. Your left one is about 650 grams. Okay. Which one is more vertical? Which lung is placed more vertical in the body, meaning it's almost vertical? The right or the left? It's the left. So the left one is the more vertical lung, right? So your lungs, they are divided into lobes by the presence of fissures. The right lung has 3 lobes: superior lobe, middle lobe, inferior lobe. And the 2 fissures that separate it into these 3 are the horizontal fissure and the oblique fissure. Right. Oblique fissure is at the level of the sixth costochondral junction. Then it meets your horizontal fissure here, somewhere in the axilla. So this is your horizontal fissure. It starts opposite the 4th costal cartilage. Right. So the difference between the right and the left is right has this superior lobe, middle lobe, and inferior lobe. For your left lung is just a superior lobe and an inferior lobe, separated by oblique fissure. Right. Then this is the hilum of the lung. Hilum is where things enter and leave the lung. So that's your hilum. So I want you to remember this before we talk about things that you have at the hilum. This is the azygous vein, right? The vein that I said is unpaired. So this azygous vein, in terms of its drainage, it drains into this superior vena cava. But before it drains there, it arcs over the root of the right lung. I think you can see that it's arcing over the root of the right lung there. Whereas on the other hand, for the left lung, there's the arc of the aorta. Right. Okay. Then there are other organs that make an impression on the lung. So this surface that I'm showing you here is what we call the mediastinal surface because it's facing the mediastinum. Right. Okay. So this is for left superior lobe, inferior lobe, with only an oblique fissure here. So um, there's no horizontal fissure for the sixth. Okay. Yeah. Okay, so I'm saying there's no horizontal fissure for the left lung. There's only that oblique fissure. Then for the right, there are the two fissures. So remember I said over the root of the right lung, there's the arc of the azygous vein. Over the root of the left lung, there's the arc of the aorta. Right. And confirm you can still see my screen.
Yeah, I can see it.
Okay, fine. So at this hilum of the lung or the root of the lung, we find the bronchus, we find the pulmonary arteries, we find the pulmonary veins that are going to and from the heart. So there is an arrangement of structures at the hilum of the lung, and that arrangement is like this. So I usually teach people this way, then they forget. I don't know why. I ask them this after 1 year, they don't know. When you're looking at this arrangement, whether it's right lung or left lung, as long as you're looking at things starting from the front, going to the back, it's VAB. You start by seeing the pulmonary veins. I think this diagram tells you here. Then you see the artery, where I'm putting the X. Then more posteriorly, you see the bronchi, where I'm putting the B there. Right. That's almost always the case for right lung and left lung. The relationship of this organ of these structures from anterior going posterior is always going to be vein, artery, bronchus. Right. The only difference starts when you're looking at their arrangement from above downwards. Right. From above downwards, it's ABV for for the left. So the most superior is the artery, followed by the bronchus, followed by the vein. So the two mnemonics, what they simply teach me here is the vein is the most inferior, but it's the most anterior. Right. Okay. So we want to start now on. Okay. So your lung has the apex here. The apex projects into the root of the neck to a point 2.5 centimeters above the junction of the lateral third and the middle third of the clavicle. Okay. Then, so that's the apex of the lung. The apex can be implicated in things like Pancoast tumor. You can get a tumor that affects the apex of the lung. That's a Pancoast tumor. Right. Or that's that Pancoast growth can compress structures that are on the thoracic outlet or your superior thoracic aperture. And one of those things that are on the root of the neck there is the lower trunks of the brachial plexus. Right. Okay. Right. So we just say that the lung has an apex. Once you mention an apex, the next thing there's a base. The base for the lung, or basically the pleura, um is where there is contact with the diaphragm. Maybe before I do bronchial tree, let me find another diagram first. Okay. So yeah, that'll be your base there. Apex is high up there. And then in terms of borders, the lung has an anterior border, inferior border, posterior border, superior border. It's always been like that. Right. Anterior border, I usually say it's from a joint to a joint. Starts opposite the sternoclavicular joint, ends where's that picture? Okay, here. So it starts opposite sternoclavicular joint, anterior border for your lung. Then it ends opposite your xiphisternal joint here. Right. So that's why I'm saying anterior border is from a joint to a joint. This is for the purpose of surface anatomy. Then posterior border of the lung, it starts opposite C7. C7, cervical vertebra number 7, that's your vertebral prominence. Then it ends around T10 vertebra. Right. Then anterior border and posterior border, they are joined by the inferior border. Right. Okay. Right. So we have a bronchial tree. Bronchial tree is how we are from the trachea dividing into the right principal bronchus and the left principal bronchus. Remember, right principal bronchus is more wider, it's shorter. Then you have a left principal bronchus. Then from the principal bronchi, you go to secondary bronchi, then tertiary bronchi, and so forth. Right. The histology will do it in a separate, just in a separate talk. The bronchial tree. Right. Then after the bronchi, you go to what we call bronchioles. We're going to have respiratory bronchioles, basically many types of bronchioles. Right. Okay. Mm. Okay. Then if you look at this left lung here, this is the upper lobe, this is the lower lobe. On the upper lobe, there's a tongue-shaped region here. And that's the lingula. Then there's a depression on that upper part. That depression here is called the cardiac notch as a result of the heart, which is in close proximity. Is that a question? Okay. Then in terms of surfaces for the lung, this surface here which faces the ribs is the costal surface. The surface on the other side where the hilum is called the mediastinal surface, and the surface on which the lung sits is the diaphragmatic surface. Right. Then I didn't mention inferior border of the lung. Inferior border of the lung follows this. 6, 8, 10. So the inferior border of the lung is opposite the 6th rib in the mid-clavicular line, opposite the 8th rib in the mid-axillary line. Then for the 10th, it crosses the 10th rib adjacent to the vertebral column. So 6th rib, it crosses the 6th, okay, the inferior border of the lung rather crosses the 6th rib in the mid-clavicular line, then the 8th rib, then it goes to the 10th rib. The difference with the lower border of pleura is it goes 8, 10, 12. Right. Okay. Right. Does anyone know where the oblique fissure for the lung starts? I know it will end at the 6th costal chondral junction, but where does it really start? Hmm?
Netflix.
Sorry,
Netflix.
Netflix, what's happening? Hello? Can you guys still hear me?
Yes.
Okay. Trying to simplify anatomy of the lung But then, can anyone tell us what's a bronchopulmonary segment? Does anyone know like what a bronchopulmonary segment is? Okay, a bronchopulmonary segment is the smallest functional unit or functional lobule of a lung, which has its own blood supply, nerve innervation. It has its own everything except the veins. So the veins are intersegmental, right? Sorry, is this not moving? Okay, so each lung has those 10 bronchopulmonary segments. I know other books will say left is 8. When they say 8, it's because of fusion. So they both have 10, right? So each bronchopulmonary segment, like I said, it is its own everything, right? It's not important for you to know the names of these bronchopulmonary segments. Same way, it's also not important to know the names of um, okay. Don't know why it's already saying 10 minutes. So far, are you guys listening to anything? Hello? Chino Tapiwa Gamo.
Listening in terms of what, Dr. G?
Everything.
Yeah.
Okay. So what's important about these lungs is the fact that remember I said the apex projects into the neck. So we auscultate for lung sounds during routine medical examinations. So the first port of call for lung auscultation will actually be in the root of the neck to hear the sounds that are in the in the apex of the lung. Right. Then when we're doing back, we mentioned something that we call an auscultatory triangle. Right. It was bounded by. Does anyone remember the boundaries of the auscultation triangle? Or you guys are cramming and forgetting? People don't want to talk to me. But anyway, it's fine. Then I want you to say something at this route. It's not shown here, but I'll mention it myself. The phrenic nerve passes anterior to the lung root, both on the left and on the right. The vagus nerve passes posterior. Right. So with respect to the lung root, the phrenic nerve, I said it passes anterior. The vagus nerve passes posterior. Okay. Okay. Then this is the This is your esophagus. Esophagus also makes an impression on on um on the lung, right? Then when small babies aspirate things, for example, a coin, it's more likely to go to the right principal bronchus and the right lung because the right principal bronchus is wider, it's shorter, right? Okay. I feel like there's really nothing much to talk about for the lung. That's maybe lung in a introductory way, but there's more to this. So people have a misconception that this tissue that you see, this flabby thing that you see is the lung. No, the lung is the system, right, down to the alveolus, which we don't see in gross, but in histology. Right. Any question on that? But please remember the issue of fissures. That right has two fissures, left has one. Then remember the surface anatomy that I told you. Anterior border from a joint to a joint. Posterior border is from C7 to T something. Um, okay. Okay. So any questions on the lung and the pleura? Forgive me, today I'm a bit tired. I had a pretty hectic day. Any questions, guys?